Dear students, Assalamu alaikum. Today we are going to discuss diagnosis and management strategies in osteoporosis. First, we are going to have an overview, then we'll discuss the problem statement, then the diagnostic modalities for osteoporosis and treatment strategies, local perspective, and call for action. International Osteoporosis Foundation or IOF defines osteoporosis as a metabolic disease in which the density and quality of bone are reduced. Or in other words, you can say that osteoporosis is a medical condition in which the bone becomes brittle and fragile. And since the bone becomes porous and fragile and the loss of bone occurs silently and progressively, therefore in most of the cases there are no warning signs of osteoporosis. So as compared to other diseases in which you have clearly defined signs and symptoms, unfortunately for osteoporosis there are no clearly defined signs and symptoms. And in many of the patients, risk of fracture is the first indication that the patient is having an underlying osteoporosis. And the important thing about these fractures in osteoporosis are that most of these fractures are fragility fractures, which means they require only a little bit of amount of trauma in order to for the patient to sustain a fracture. And therefore osteoporosis is also known as a silent disease. Osteoporosis can be broadly classified into two: the primary osteoporosis and the secondary osteoporosis. The primary osteoporosis is further subdivided into two categories. Number one is the type 1 or the postmenopausal osteoporosis that is common in elderly female after the onset of menopause. Type 2 is known as the senile osteoporosis, or in other words it is the age-related osteoporosis. It is more common in men, but it can also occur in females who reach for age more than 65 years of age. Apart from that, there is a secondary osteoporosis, and secondary osteoporosis means that there is a clearly defined cause for that osteoporosis, and that cause can be of many types. For example, renal osteodystrophy, metabolic dysfunction, diabetes mellitus, chronic use of corticosteroids, and certain other medication and other risk factors that we are going to discuss soon. Now, why is osteoporosis a major issue or a problem all around the globe? Again, it is because of the fragility fractures. It has been estimated that around 1 in 3 women over 50 years of age will experience an osteoporotic fracture, as well as 1 in 5 men. So this means that this particular disease carries a high morbidity and can ultimately lead to mortality if not treated well. These osteoporotic fractures are most common at the hip, specifically at the neck of femur, at the spine, specifically at the lumbar spine, and at the wrist, that is in the distal wrist. The vertebral fracture can result in serious consequences, including loss of height, intense back pain, and a deformity which is known as Dwagger's hump. Now this is a picture of Dwagger's hump. As you can see that the patient is not only in pain, but he or she bends forward and it becomes difficult for them to mobilize and move around independently without having reliance on someone else. Apart from that, if the patient sustains a fractured neck of femur, this means they often require surgery. And surgery in case of an osteoporotic compression fracture is very challenging, because the bone mass is already compromised and it is very difficult for the orthopedic surgeon to put in a surgical implant. Fractured neck of femur and the resulting surgery also leads to a long period of immobility. During this immobility, patient loses their independence. They are at high risk of sarcopenia, immobility syndrome, and muscle wasting. In addition, they are also at high risk of thromboembolism in form of deep vein thrombosis and pulmonary embolism, which can actually lead to death of the patient. Now coming towards who is at risk of osteoporosis, you can divide the risk factors of osteoporosis into two: fixed risk factors which cannot be modified or which cannot be changed, These include age, which means if the patient is elderly, he or she is at higher risk for developing osteoporosis. Female genders. Female are at more risk of developing osteoporosis because of the menopause. Family history of osteoporosis. If the patient has a family history of osteoporosis in his or her first degree relative, he or she is at high risk of developing osteoporotic fractures. If the patient already has developed one previous fracture, he or she should be very careful because they are at high risk of developing another fracture. Menopause and hysterectomy places the ladies at high risk of developing osteoporosis. If the patient has been given long-term glucocorticoid or steroid therapy because of many reasons, again it leads to fragility of the bones and places the patient at high risk of osteoporosis. Rheumatoid arthritis is a multi-system inflammatory disease which primarily involves the joint but also has certain extra-articular manifestation. So the extra-articular manifestation of rheumatoid arthritis in the musculoskeletal system manifests in form of osteoporosis. Now this osteoporosis in rheumatoid arthritis can be because of the disease itself, number one, and it can also be because of the effects of the drugs that we give for rheumatoid arthritis, specifically oral corticosteroids. Then primary and secondary hypogonadism in men, which leads to a reduction in the serum testosterone level, also puts the male at a high risk of developing osteoporosis. Modifiable risk factors are those which can be modified if the patient gives them some attention. High consumption of alcohol and caffeine leads to an increased risk of osteoporosis. Smoking puts the smoker at high risk. Low body mass index puts the patient at high risk, and surprisingly, patients who are obese are not at a higher risk of osteoporosis as compared to people who are very thin, skinny and smart. Poor nutrition, and specifically nutrition poor in protein, calcium and milk, puts the patient at high risk of osteoporosis. Vitamin D deficiency is directly linked to osteoporosis. If the patient is not very active and he or she does not perform adequate exercise at least 3 times a week, again they are at high risk of osteoporosis. Low dietary calcium intake, because remember, calcium acts as the building block of the bones. So if you don't take calcium adequately while you are young, while you are less than 30 years of age, or you don't take supplements when you are more than 40 years of age, you are more liable to develop osteoporosis and osteoporotic compression fractures. If the patient already has a history of frequent fall, again they are at more risk for developing osteoporosis. Now, how do you diagnose a case of osteoporosis? The main diagnostic aid of osteoporosis is radiology, but sometimes you have to rule out the secondary causes of osteoporosis, and for that you have to do certain laboratory tests. So you can go for either a complete blood count along with the erythrocyte sedimentation rate or the ESR, electrolyte like sodium and potassium, along with creatinine to see the condition of the kidneys, serum calcium to see the level of serum calcium, serum phosphorus, which is again a bone marker, serum albumin because calcium is bound to albumin in the human body, serum alkaline phosphatase, which is a marker of damage to the bone, liver enzymes, and 24-hour urinary calcium. These are not mandatory tests, but in some cases you have to do these tests in order to rule out secondary osteoporosis. The main assessment of bone mineral density is done by the radiology, and in the radiology the conventional x-rays are not reliable. Please remember that. So do not diagnose osteoporosis on x-rays, or do not advise x-rays if you are suspecting a patient to be having osteoporosis, because it needs a lot of loss of bone mass before osteoporosis becomes apparent on x-rays. So the most reliable, the gold standard tool for the diagnosis of osteoporosis is DEXA, or dual energy X-ray absorptiometry. It is non-invasive. It can be performed within 5 to 10 minutes, and the report can be generated within the next half an hour. It does not require any extra preparation on the part of the patient, and you don't even have to undress the patient. So it's very convenient, and it is now freely available all around Pakistan, at least in all major cities. It basically measures the bone mass at the forearm, at the hip, the spine, finger and heel. Apart from that, you can also use a computer tomography or CT to do the quantitative CT, which measures the amount of bone at the spine, hip and forearm and reliably indicates whether the patient is having osteoporosis or not. Another thing that is commonly used is quantitative ultrasound, and you might have seen people, the pharmaceutical people who have their stalls in malls or in public places, and they offer that you're going to check your serum calcium and this bone health. So they actually use this quantitative ultrasound, which measures the bone mineral density at the heel or the finger. But remember, of all these three things, DEXA, QCT and QUS is the most unreliable. So please go for a DEXA scan wherever available, because it is the gold standard. Now a little bit more about the DEXA scan. A DEXA scan, how it works. So basically the DEXA scan compares the patient's bone mineral density with the bone density expected for a young healthy adult or a healthy adult of her own age, gender and ethnicity. So the normative data is already available, but the problem is that most of the normative data, it actually comes from the Caucasian or from the European or the Northern American population. So there is a need to develop up our own local Asian and Pakistani database as well. And the difference is calculated as a standard deviation. The difference between the patient measurement and that of a young healthy adult is known as the T-score, and this is the most commonly reported in the reports. Whereas the difference between the patient's BMD measurement and the measurement of someone of the same age is known as the Z-score. That's why in cases of adults, whenever we do BMD, we try to calculate the T-score, and in case of pediatric population, we try to calculate the Z-score, because you cannot compare a pediatric patient with a normal healthy adult. So in adults it's the T-score, in the children it is the Z-score. So how do you interpret this T-score? World Health Organization has recommended a classification scheme which we follow, and the classification scheme is based on, number one, whether you declare a patient normal, osteopenic or osteoporotic based on the bone mineral density at the hip joint as assessed by a DEXA scan machine. So if the T-score is -1 or above, it is a normal bone. If the T-score varies between -1 and -2.5, you would label it as a case of osteopenia. And if there's a T-score of -2.5, it is a case of osteoporosis. And if case of severe osteoporosis, there is a T-score of more than -2.5 or lower, and presence of at least one fragility fracture either in the hip, the wrist or the spine. So this is the classification of osteoporosis based on the T-score as proposed by the World Health Organization, and you should be knowing it. Now what are the indications for DEXA scan? It is seen that many times, especially in the private setup, even young people, young females, they come and ask for a DEXA scan. Now DEXA scan is a highly specialized radiological investigation. Although the risk of radiation is very low, but still there is no need of wasting this resource if the patient does not qualify for DEXA scan. So there are pretty well defined indications for doing DEXA scan in any male or female, and these include, number one, if the patient presents with fracture after a minor fall, that he or she simply stumbled from the chair or on the stairs and he developed a fracture of the spine or the hip or the wrist. So in that young patient, you might want to do a DEXA scan. If the patient has a history of early menopause or hysterectomy before 45 years of age and they are not using any hormone replacement therapy, they are at high risk of developing osteoporosis and they are a candidate for DEXA scan evaluation. If the patient has a family history of hip fractures on a body mass index of less than 21, that is, they are very thin and lean, again they are at high risk of osteoporosis and candidate for DEXA scan. If the patient has diagnosed conditions that lead to osteoporosis, for example, renal osteodystrophy, patient is on chronic corticosteroids, patient is a case of chronic uncontrolled diabetes mellitus, patient is having uremia. So all these conditions that lead to secondary osteoporosis, in these cases you can ask for a DEXA scan. If the patient is using oral glucocorticoid for more than 3-month duration, again you might want to consider a DEXA scan to see what is the bone health of the patient or whether he or she has not developed osteoporosis. Coming to the treatment options, you can divide them into 4: prevention and lifestyle modification, calcium and vitamin D supplementation, anti-resorptive agents or the use of anabolic agents, and surgical management if the patient presents with an osteoporotic fragility fracture. Unfortunately, prevention and lifestyle modification is the most neglected aspect of management of osteoporosis, at least in developing countries like Pakistan. पाकिस्तान में आप किसी डॉक्टर के पास चले जाएं, जो पहली बात वो करेगा वो आपको दवाइयाँ देगा और खूब दवाइयाँ देगा, और अच्छा डॉक्टर वो होता है जो ज़्यादा दवाइयाँ देता है. अनफॉर्चुनेटली हमारे डॉक्टर भी मतलब कि मेंटेलिटी ये बन चुकी है और मरीज भी सिर्फ दवाइयाँ मांगते हैं. So this is a very unfortunate part that we do not focus on the prevention and lifestyle modification in case of a suspected osteoporosis. Prevention is absolutely important because identifying and treatment patient at risk of fracture but who have not yet sustained a fracture will substantially reduce the long-term burden of osteoporosis. असल कमाल तो ये कि आप at high risk patient को identify करें, फिर intervention करें by certain ये lifestyle modification and dietary habits, और ताकि patient का वो fracture prevent हो जाए जो उसने होना था. That's the real thing. And apart from that, you can also use FRAX. FRAX is a fracture risk assessment tool. It is an online tool that is available online. It has been endorsed by World Health Organization and International Osteoporosis Foundation. ये freely available है. आप online जाके अपने parents का या अपने grandparents का या आपके घर में अगर कोई senior citizen हैं, आप उनका भी fracture risk assessment जो है वो assess कर सकते हैं कि what is their risk of developing an osteoporotic fracture over the next 10 years. The FREX algorithm, they give you the 10-year probability of risk. The second step is the role of exercise and mobility. I just told you that if you are more active, you don't develop sarcopenia, biomechanically जो Haversian canal है और क्या जो bone का structure है, it maintains and the patient is at less risk of developing osteoporosis. Apart from that, you have to maintain good nutrition. The nutrition must include dairy products, and by dairy products we not only mean the milk, it includes milk, butter, cheese, and things made out of dairy products. Apart from that, you should actually reduce use of drugs like corticosteroids if they are not indicated, and even the excessive use of proton pump inhibitors, the medicine which are used to manage dyspepsia, they are associated with development of high risk of osteoporosis. Apart from that, regular calcium and vitamin D supplementation is very important, and calcium supplementation should again vary on the patient and age, but usually the recommended dosage is from 800 mg to 1500 mg per day. Similarly, the vitamin D supplementation ranges from 400 international units to around 800 international units per day for an adult. The vitamin D is nowadays, at least in Pakistan, it comes in both in all forms. It comes in the oral form, either in form of a tablet or in form of gel capsule, and it also comes in form of an injection which can be given either intramuscularly or can be consumed as a oral drug. So whatever the patient is convenient, you must offer him calcium and vitamin D supplementations. But probably a very important thing that often get neglected is to ensure the compliance of the patient to the treatment. So नुस्खा लिखना कोई कमाल नहीं है, कोई भी किताब देख के नुस्खा लिख सकता है. अच्छा डॉक्टर वो होता है जो अपने पेशेंट की compliance to treatment ensure करता है. This is a separate सब टॉपिक, इसमें हम बात नहीं करेंगे, बट अगेन इसमें बहुत सारी क्या नाम है ऑप्शन हो सकती हैं. SMS रिमाइंडर से लेकर अलर्ट लगा सकते हैं, घर में आप क्या नाम है जो ड्रग डायरी मेंटेन कर सकते हैं, जब पेशेंट अपना मेडिसिन टाइम पे ले तो कोई और बंदा घर का उसको टिक करे, एंड देयर सो मेनी ऑप्शन टू improve the compliance of the patient to the treatment. Now specifically coming to the pharmacological management of osteoporosis, you can broadly divide these into two: the anti-resorptive agent and the anabolic agents. The anti-resorptive agent first of all include the estrogen, then selective estrogen receptor modulators, or what we call SERMs, and the most commonly and frequently used, which we are going to discuss right now, the bisphosphonates. The other category is anabolic agents, and the important one are three: parathyroid hormone, teriparatide, and strontium granulate. Out of these, the parathyroid hormone and teriparatide, they are given as subcutaneous injection, and strontium granulate comes in form of a powder sachet, and it has to be dissolved in a glass of water and consumed on a daily basis. But please remember that parathyroid hormone and teriparatide are very costly treatment options. and even the strontium alendronate is pretty costly when given on a daily basis. Now coming to the bisphosphonates are one of the most common and used agents for management of osteoporosis. They are classified as an anti-resorptive agents because they are potent inhibitors of bone resorption and inhibit the activity of osteoclasts. So what happens that whenever you give bisphosphonate, whether orally or whether by intravenous route, the bisphosphonate, it goes into the blood and it goes to the bone level, and there it attaches to the hydroxyapatite crystal of the bone. Now we know that in osteoporosis, the osteoclastic activity is more than the osteoblastic activity. So whenever the osteoclast, it imbibes or it bites that part of the bone that is impregnated with hydroxyapatite attached to the bisphosphonate, that bisphosphonate, once it goes inside the body of the osteoclast cell, it releases and it bursts open the membrane of that osteoclast, leading to death of the osteoclast. So it is basically anti-resorptive, that it reduces the resorption of the bone by the osteoclast. Almost all of the FDA approved bisphosphonate have shown to reduce vertebral disc fracture and increase bone mineral density, where some of them have demonstrated reduction in non-vertebral and hip fracture risk as well. Again, because bisphosphonate are also associated with certain side effects, most commonly the gastrointestinal side effects, and along with a poor quality of bone and also subtrochanteric fractures of the neck of femur. So there are very clear indication of you starting bisphosphonate, because bisphosphonate are not a short-term medicine. Bisphosphonate have to be given to the patient for years, at least 2 to 5 years. So you have to choose very carefully whether the patient is a candidate for bisphosphonate treatment or not. So some of the recommended indication are: number one, if in a postmenopausal women and men more than 50 years of age who present with any of these. Number one, with fragility, hip fracture, or an osteoporotic compression fracture of the vertebral spine. If on DEXA scan the T-score is less than 2.5 at the femoral neck, total hip or spine, after appropriate evaluation to exclude secondary causes. So you exclude the secondary causes and the DEXA scan shows a T-score of less than minus 2.5. This is a candidate for bisphosphonate oral or IV therapy. If the patient has a low bone mass and a 10-year probability of hip fracture of around 3 years as calculated by the online FRAC scale, so it is also an indication for starting bisphosphonates. If the 10-year probability of major osteoporosis related fracture is 20% as based on the FRAX calculation, again this patient should be started off on osteoporosis on bisphosphonate. Bisphosphonate, they come in different forms. They can be given orally. There are certain bisphosphonate like alendronate sodium, rhizandronate, which are purely given only by oral route. Ibandronate is given both orally and IV, and zoledronic acid is given only as IV infusion. So alendronate also comes in many forms. There is a 10 milligram tablet which has to be taken daily, which is obviously very inconvenient. Then there is a 70 milligram tablet to be taken every week. As compared to that, the rhizandronate and ibandronate, these are the monthly preparation, and you have to only take one tablet every month. If you give ibandronate intravenously, then you have to give it every 3 months. And zoledronic acid is a 5 milligram infusion which is to be given once every year. So it all depends on the patient condition, affordability, and then you have to decide after discussing with the patient what kind of route you are going to follow. Now coming to which drug to prescribe. Number one, obviously you have to ask for the preference of the patient and their convenience. So we are going to discuss the protocol of administering taking these medicine. So this protocol might not be very convenient for some patient, and they might want to go for the monthly preparation, the 3 monthly or yearly preparation. So you have to discuss all these things with the patient before you prescribe and write your prescription. Then you have to maintain adherence to the dosing schedule. For example, I just told you that alendronate sodium is also available in 10 milligram daily. Now it's pretty difficult for an elderly patient to take 10 milligram medicine daily. So it's better that you give them either 70 milligram weekly preparation or 150 milligram monthly preparation. So adherence is a major issue, and you have to address that. Cost is another issue. For example, in case of the zoledronic acid, it is supposed to be the most costly. Then again, in case of teriparatide, again it's a very costly hormone. So you have to discuss all these things with the patient before you prescribe. Research has shown that the most cost-effective initial therapy of postmenopausal osteoporosis is either generic oral alendronate sodium or generic parenteral zoledronate. So either you give them a single shot of zoledronic acid once a year, or you put them on oral alendronate sodium once per every week. The cost comes out to be equal at the end of the day. Now, there is a recommended specific protocol for giving oral bisphosphonate which must be followed in order to reduce the incidence of side effects like reflux, esophagitis and gastritis, and also to improve the absorption of that drug in the blood. Number one, the patient should take the medication with 2 to 3 glasses of water early in the morning on an empty stomach. That is before he or she takes the breakfast. Patient should not lie down or bend over or eat anything for at least 30 to 60 minutes. It is even recommended that the patient should actually walk around after taking bisphosphonate. This would reduce the incidence of esophageal reflux. And when the recommended wait time of 30 to 60 minutes is over, it is important that the patient must take breakfast to neutralize the remaining medication. Duration of treatment, again, it is not very much clear, but research shows that bisphosphonate can persist in their efficacy for longer terms, 7 to 10 years with strong safety profile. That is, in some cases, the oral bisphosphonate were used for 7 to 10 years. They persisted in the blood and in the bone, and they offered their effect without any major side effects. So bisphosphonate can be used for longer period of time. But the important thing to realize is that duration and potential discontinuation of treatment should be personalized for individual patient. So it is not one size that fits all. You have to decide for each individual patient depending on their response to treatment, fracture risk and their other comorbidities. So it has to be tailor made for every patient, that how long this patient is going to have bisphosphonate. But at the minimum it should be at least 2 to 3 years. Another recommended principle is that whenever the patient is on bisphosphonate oral IV for at least 2 to 3 years, you might want to redo or this DEXA scan and then evaluate the T-score. So in patient who have a T-score less than 2.5 or who have suffered a new fracture while on treatment should continue the treatment with bisphosphonate. While patient with T-score more than -2.5, that is they improved, they could be considered for discontinuation of active treatment while undergoing continued monitoring of their bone health. So if the T-score remains the same or it worsens or the patient develops another osteoporotic compression fracture, you must continue the bisphosphonate. If they get better, you can stop the bisphosphonate, but please keep on monitoring your patient on long-term basis. Now, few words about zoledronic acid, which is an IV bisphosphonate. The advantages of IV bisphosphonate are that they reduce the gastric irritation and side effect. Ease of administration, you only have to give a single shot of zoledronic acid over a time period of 20 to 30 minutes once a year. You don't have to follow that protocol of taking oral bisphosphonate, then standing up for 30 to 60 minutes, then taking it on an empty stomach with 3 glasses of water. So it is pretty easier. And obviously the compliance of the patient is much better. If you ask the patient to get 1 shot of bisphosphonate every year as compared to taking bisphosphonate every day, every week or every month, the compliance is going to be much better in cases where they have to undergo a single shot of IV zoledronic acid, the bisphosphonate. There is a specific protocol for administering zoledronic acid. I will quickly go through that. First of all, you have to check the creatinine level, the serum urea creatinine, because if the patient has renal dysfunction, the amount of the zoledronic acid has to be adjusted. Then you have to ensure hydration. Ask the patient to take lot of water 2 to 3 days before the administration of IV zoledronic acid. You might actually want to give him or her 1 liter of normal saline 1 to 2 hours before the administration of zoledronic acid. Then you also have to measure and ensure that the calcium and vitamin D levels are okay. Please remember, example hai ke like this bisphosphonate is like cement and the calcium vitamin D is like bricks. So you cannot build a wall or a bone if you don't have bricks. You cannot build it only based on cement. So you need cement, which is calcium and vitamin D, and you need bricks, which is calcium and vitamin D, and you need cement, which is bisphosphonate. So दोनों का होना और optimal होना बहुत ज़रूरी है. So please check it beforehand. Then the patient should be detained in ward and emergency, ideally because you might have untoward reaction. Then give the patient prophylactic paracetamol around 2 tablets 30 milligram prior to infusion. It is a single intravenous infusion over 15 to 20 minutes. You have to check the vital sign and observe for around 45 minutes. And if the patient is stable, you can always send him or her back and ask him to follow up after 4 weeks. Zoledronic acid has shown to be safe. It has an acceptable safety profile. No adverse events were considered to be drug related, and treatment with zoledronic acid improved bone health even in high risk patients. So it's a very effective agent. The only issue is it's a bit costly. आजकल इसकी प्राइस तकरीबन मेरे ख्याल में जब से नया पाकिस्तान बना है और डॉलर ऊपर चला गया है तो इसकी प्राइस तकरीबन प्रॉब्ली मेरे ख्याल में 22 से लेकर 26,000 के दरमियान है. बट इट्स वेरी इफेक्टिव, और अगर आपके पेरेंट्स में से किसी को हो तो प्लीज़ डू कंसिडर दिस बिस्फॉस्फोनेट. The important thing is that this zoledronic acid persists for long term, and research shows that the anti-resorptive activity of a single dose of zoledronic acid of 1 to 5 milligram persists for at least 3 years in postmenopausal women with osteopenia. So up to 3 years की single 1 to 5 milligram की dose भी persist करती है. Apart from that, the last thing is that sometimes the patient might present to you with osteoporotic compression fracture. And not every patient of osteoporotic compression fracture is a candidate for surgery. Now, in some osteoporotic compression fractures, specifically the vertebral fracture, there are things like kyphoplasty, balloon kyphoplasty and vertebroplasty. So, vertebroplasty is a procedure in which under local anesthesia, the spinal surgeon or the orthopedic surgeon or the rehabilitation consultant, they put a needle inside the vertebra that has been compressed, and they put in a special bone cement known as methyl methacrylate inside the vertebra. Another option is balloon vertebroplasty, in which they first of all put in a little balloon inside the vertebra. They blow the balloon in order for the vertebra to regain the height, and once the vertebra regains a little bit of height, then they fill in the balloon with bone cement or methyl methacrylate. But apart from that, in many patients with osteoporotic compression fracture, they either cannot afford these treatment or they are not candidate for these treatment on a medical ground. But they have pain and they are bedbound. What to do? So here rehabilitation can help a lot regarding pain management and exercise therapy. So first of all, you need to understand that yes, obviously patient is having severe pain, osteoporosis, bone fracture. So you have to advise immobilization, but please give them immobilization for 3 to 5 days maximum, or till the time the pain is a little bit better or relieved. So as soon as the patient is better, please try to make them sit in the bed, by the bed, in the chair, in the wheelchair, and ask them to move around with support. Because if you allow the patient to lie down in the bed for a long period of time, they are going to develop sarcopenia, muscle wasting, contracture, and other symptoms of immobilization syndrome. Pain relief is absolutely important, and initially you might have to give them intravenous and intramuscular NSAIDs, tramadols, ketorolac, which is toradol, which is the only NSAID that can be given as IV. Then you also might want to give them other adjunct medicine like prothiazide or muscle relaxant or diazepam to alleviate the anxiety. In some cases, the use of subcutaneous or nasal spray of calcitonin is very effective in relieving pain associated with vertebral compression fractures. Then you have to do patient education and tell them why did this happen and what they can do to reduce their future risk for osteoporosis and what are the different treatment options available to them. Even if the patient is immobilized and is unable to move around, you can always advise them certain exercises that can be easily done by any patient of any age, even if he or she is lying in the bed with an osteoporotic fracture. These include gentle exercises like deep breathing exercises, quadricep exercises, neuromuscular thoracic spine mobilization without putting much pressure on the diseased segment or the fractured segment. And in order to enhance the mobility and reduce the pain and improve the posture, you can use the spinal orthotics, and we discussed the spinal orthotics in our lecture on upper and lower limb orthotics, and there are different kind of orthotics available which you can utilize. The last thing is some local perspective on osteoporosis in Pakistan and developing countries. Please remember that osteoporosis is pretty common in Pakistan. Just because it is underdiagnosed, patients don't have any idea, even doctors don't have any idea how to screen for that and how to diagnose it, does not mean it's not here. It is very much prevalent in Pakistan and leads to a lot of morbidity and mortality. The eye cannot see what the mind doesn't know. So if you don't know how to pick up osteoporosis, if you don't know what is primary and secondary osteoporosis, what is senile osteoporosis, what is postmenopausal osteoporosis, what is the best test for evaluation of osteoporosis, how to evaluate secondary osteoporosis, I'm sorry, you will not be able to diagnose osteoporosis accurately. So the eye cannot see what the mind doesn't know. A delay in diagnosis and use of inappropriate investigation is not only a financial burden for the patient, it also reduces their mobility, enhances the misery of the patient and the attendants, and also reduces the quality of life. And this ultimately leads to an increased cost of treatment for the patient. So whenever you are deciding a treatment protocol for the patient, please do discuss the finances of the patient with them. There is absolutely no fun in giving a ज़बरदस्त kind of prescription कि डॉक्टर ने नुस्खा बड़ा ज़बरदस्त लिख दिया, पेशेंट ना अफोर्ड कर सकता है ना समझ सकता है. सो ये आपको ये नुस्खा सिर्फ बस एकेडमिक एक्सरसाइज थी और आपको कहना मैं ना ईगो मसाज हो गया कि आपकी बहुत बड़े प्रोफेसर हैं, बहुत बड़े आप कंसल्टेंट हैं, लेकिन मरीज को उसको कतन कोई फ़ायदा नहीं हुआ. सो प्लीज़ ऑलवेज डिस्कस द ट्रीटमेंट प्रोटोकॉल मैनेजमेंट स्ट्रेटजीज विद योर पेशेंट इन एनी डिजीज़ इंक्लूडिंग osteoporosis. So how can you help as student or as doctors to be? First of all, please identify high risk cases. हमने अभी बात की थी modifiable risk factors, non-modifiable risk factors. Please look around, look in your elderly, look in your grandparents, look in your family members, in your senior colleagues. अगर किसी को ये risk factors हैं तो उनको guide कीजिए the value of nutrition, how to take and how much amount of appropriate calcium and vitamin D supplementation they need to take. कौन सी चीज़ें वो खाएं, कौन सी चीज़ें ना खाएं. Guide them regarding dietary products, guide them regarding the misuse of caffeine, तो ये and the use of corticosteroids. Apart from that, if you encounter a patient with osteoporotic fracture, a prompt management focusing on adequate pain relief and early mobilization should be your first task. एंड जब अल्लाह आपको मौका दे और आप उस स्टेज पे पहुँचो जहाँ आप एडमिनिस्ट्रेटर्स बनो, कंसल्टेंट बनो, अपने हेड ऑफ डिपार्टमेंट बनो, सो प्लीज़ ट्राई टू एस्टेब्लिश फ्रैक्चर liaison services between different specialties, because literature search has shown that in departments and in institutes where they have a established fracture liaison service, the management of osteoporosis is very up to date and very effective in those setups. So thank you very much. It was a pleasure giving these 7 lectures to you all. I hope कि आपको इसमें से कुछ समझ आया होगा. अगर आपको कुछ समझ नहीं आया, so please leave your questions on Padlet, and please if you need a copy of the presentation, feel free to email me at farooqrathore@gmail.com. अपना बहुत ख्याल रखिएगा. Thank you very much. Assalamu alaikum.